So first thing is remove the shoes and socks. Means you start your examination from foot to head. I never say that you examine in diabetics from head to foot. You start your examination from foot to head. Apadamastaka in Sanskrit. So that is very important. So you are not going to miss the foot complication. That is very important. Then I think everybody knows about this. No LOPS, loss of protective sensation, no PAD, no deformity. It is a low risk category. So annually a journalist or diabetologist can follow. If there is LOPS plus minus deformity every 3 to 6 months, if PAD plus minus LOPS every 2-3 months, ulcer or history of amputation or Charcot's foot, not every 1 to 2 months when our patient comes, even every 15 days or sometimes a week. So that is there. So there are two types of examination, because in busy clinical practice, as we were discussing, who is going to have this? This is a PHQ-9 or SF36, which is bigger one, which he have shown you. In that situation, the problem arises, you go for a 60 seconds examination. And if you find it's positive, then go for a 3-minute examination. So any previous diabetes related foot problem or both feet pulses are palpable. So very simple. It's absent, feeble, palpable or bounding. So by that you can differentiate. It's a neuropathic, it's normal or it's ischemic. By just putting your fingers on the dorsal pedis and tibialis posterior. Is protective sensation intact? Just by doing a 10 gram monofilament. Is there any evidence of significant foot deformity? So what you ask, so look, this is there, and then 3 minutes foot examination. What to ask, what to look, and what to teach. These are the 3 minutes examination. So one is what to ask about the history, previous history of angioplasties or stent or leg bypass surgery, there is a pedal bypass, history of smoking, all these things. About the examination or what to look for, dermatological examination, neurological examination, especially loss of protective sensation or monofilament or biothiometer, and then you can have musculoskeletal examination and vascular examination, as I asked, that palpate at least the pedal pulses. Then what to teach, recommendations, foot care, and then education regarding the shoes. Recommend appropriate footwear and advise against shoes that are too small, tight or rub against a particular area of the foot, and yearly replacement of shoes. As the insole bottoms out very fast, you can even go for early replacement every 3 months. So neuropathic assessment, I think everybody knows it. It's very simple. Great toe, first and fifth empty head, these 3 are optional. Out of these 3, if 2 are not, patient is not able to feel, means there is lots of protective sensation. This one is the, you may take 4th one, or these are the 5. So but these 3 is suffice. Great toe, first and fifth empty head. Out of these 3, if 2 are there, absent means loss of protective sensation. The biothiometer more than 25 volts is there. This is very much common in all over the country. I can say the people are working on this fire. So loss of pain and temperature perception, gift of pain, gift of God. Pain we used to say in diabetic neuropathy is the gift of God. So loss of protective sensation, gift of pain is lost, and they are able to, and they will have burns, and that may lead to disaster and even the major amputation. Sometimes they may land with the autonomic neuropathy. This is, you see, a simple thing. We come across this one. This is a Stapler pills, 52 years male, came to us, non-healing ulcer since long and 1 year, and we find foreign body staplers. So you see, it was on account of neuropathy. Patient was not having any pain. So loss of protective sensation was there. So what you have not to miss in examination, palpation of the pedal pulses, and what you will see for it, edema, bony, what we all see in our day-to-day clinical practice. In the beginning I told I'll keep my presentation very simple and basic. That's there. And then after doing the examination, you can categorize risk category 0, 1, 2, 3. 0, normal plantar cessation, means low risk. If it is a loss of protective sensation, moderate risk. Loss of protective LOPS plus high pressure areas or foot deformities or onychomycosis, high risk. If history of amputation or neuropathic fractures, means Charcot's or peripheral vasculitis, is a very high risk. This is a simple way you can identify. So points that should be covered when instruct the patient at the risk of foot ulceration. One, explain the need to perform daily foot inspection of the entire surface of the both feet, including areas between the toes. Interdigital mycosis is very common. Sometimes that may cause the problem. You can see it. The interdigital mycosis, you can see this is very much there, and you have to treat it. Otherwise, it may create the problem. And then avoid walking barefoot even at indoors, because there is a loss of protective sensation, and that may cause the problem. This is the fungal infection of the nails, you can say, and these sharp and long nails can cause injury to adjacent shoes. Identify at-risk feet annually for signs, symptoms of loss of protective sensation and peripheral arterial disease. Regularly inspecting and examining the at-risk feet, history of foot ulceration, history of lower extremity amputation, diagnosis of end-stage renal disease. Mind is renal, foot is very difficult to heal, because the circulation is also impaired, calcified arteries are there, and we all know what is the mechanism is going on, so that causes more problem. So educating the patient, family and healthcare providers, and it should be structured about the self foot management. So the patient education, you can give single, alone, or you can give in the groups. So how you can give it, and this is very important, repeated education. Suppose today patient comes, you have explained them, and even after 1 week or 2 weeks patient comes, again give the same sort of repetitive education regarding the foot care, then only they understand. Even after that, they don't follow. This is the biggest problem what we see in day-to-day clinical practice. That is there. Foot care education for diabetic educators, you have to have your team, because it's a teamwork. Diabetes care is now a teamwork, we all know, for everything. You take anything, but especially the foot care, as everybody have mentioned, is the not only the dietitians or educators, podiatrists, vascular surgeons, plastic surgeons, surgeons, orthopedic surgeons, all team members. So it's a teamwork. Without that, you cannot treat the diabetic foot. Then the foot care education for the diabetic nursing team, that should be a regular practice you have to do all for your patients. Physicians education, very important, because when to refer, this is very important, and if minor pathologies are there, how to handle and how to treat. Then about the footwears, it's mostly asked question. Dr. Foot, I'm talking the Bengali. So where will going to get these sort of footwears? So you see, there are 3 types of footwear: preventive, therapeutic and customized. Believe me, customized footwears are required only in less than 5% of the patients. Most of the patients require, if they are in no loss of protective sensation, and then you can use the preventive footwear, only LOPS. If therapeutic is required, then it is also available, easy. Customized hardly less than 5%. So preventive footwear, proper comfort protection, having soft leather, lining, built-in heel cushion pad, rounded white toy. Toy box should be white, foam padded, and these are the ideal example of the preventive footwear. Then comes the therapeutic footwear. So always remember, these are the important things. One is the white toy box. Another is the good and strong counter heel. Third is the tough and outer insole. And the soft and extra depth insole. That is important. And the well padded inner surface protects from injury. So these are the therapeutic footwear. I think in all across the country, everywhere these are available. So that is not a problem. Then comes the customized. What I'm talking, less than 5% of the patients are requiring. So if the 4-foot amputation is there, so you require customized footwear. So for that, you have to go for it. So for these also, it's available. Then what is the guide to footwear prescriptions? If deformity, prior plantar callus, high plantar pressures, none, sports shoe will do. If moderate, sports or depth shoe with a thick sole, or severe, then customize a per customer shoe. These are the guidelines. Shoe fitting, very simple. Ask the patient to have a white toy box, not like this pointed shoes, which may create a problem. So ensuring routine wear of appropriate footwear, therapeutic footwear that has a demonstrated plantar relieving effect during walking to help reduce the recurrence of plantar ulcers. This is also important. Provide appropriate treatment for any pre-ulcerative signs or abundant callus on the foot, for ingrowing toenails and for fungal infections of the foot. I am just going to show you this treating risk factor for ulceration. This patient comes to us just 2-3 days back. These were the multiple callus, the great toe, 3rd and 5th empty areas, you see. And what is there? What is the treatment for it? So as it was a loss of protective sensation, that's why you have got it. We have removed the callus. You can do in your clinic. You doesn't require a help of any surgeon. And you can see, so things has been done. Quite okay. And advise them to have a therapeutic footwear, or you can advise them to go for a preventive footwear. So that will be suffice. That is important. So integrated foot care. So provide integrated foot care for person with diabetes who is at risk of foot ulceration. So foot care, as I have shown you, what you will do, nibbling of the nails, removal of the callus and all these, and about the amputations. Major and minor, this is the how the sequel runs and ultimately lead to the amputation. What are the risk factors for amputation? As these are the risk factors for the ulceration. These are practically same. So what you can see it. So what are the basic tenets of diabetic foot management? So I have discussed this, and I'm just going to take 2 more minutes. I've got a liberty because I think one speaker is absent, so I can go for it. So is that. So basic tenets, always remember, adequate debridement and infection control is one. Adequate vascularity and adequate offloading means your ulcers are going to heal. And how you will define the healing? If a person's ulcer is reduced by 15% per week, means healing is adequate, or 50% in 4 weeks means it's adequately healing. So about the debridement first, and then infection control. So empiric antibiotic regime based on clinical severity of DFIs. So one thing always remember, before starting any antibiotics, you have to classify as a mild, moderate or severe, whatever there, and take a deep tissue culture. Deep tissue culture, mind it is not the pus or superficial. Take a deep tissue culture and then send it and start the empiric antibiotics. And after the culture reports, you can de-escalate or you can escalate the antibiotic therapy. That is the basic thing. So one is the most common infections is the Staph aureus and then Streptococcus. Mild infection, then you can use the amoxicillin clavulanic acid, or you can use with the quinolones, levofloxacillin. If you are suspecting MRSA, then doxycycline will suffice. So generally the diabetic foot infections are multi-organism. So both gram positive, gram negative coverage should be there. It's a mild infection. Then moderate to severe infection. I'll simplify this slide in another way. Yes, this one. So this is the non-limb threatening and life threatening, or you can say mild, moderate or severe. So clindamycin plus levofloxacillin, or you can go for piperacillin tazobactam plus ciprofloxacillin, or you can go for linezolid, or if the life threatening or severe infection, you can directly go for the meropenem plus imipenem or meropenem, plus you can go for the teicoplanin combination, and according to culture sensitivity you can escalate or de-escalate. You have to manage the comorbidities. We all know in these patients they are highly comorbid conditions are there. That is very important. Then TCC, we used to say total contact cast is the gold standard in management of total diabetic foot. But nowadays scenario is changing. TCC with window, instant TCC, we have got a lot of modifications in this cast, and we have started with the posterior slab with insoles, and we have presented our papers in international forums on particularly these issues. You can have removal TCC, then screw, then you can have modified footwears and indigenous offloading techniques. So which I am going to just show you. This is a very important indigenous technique. Suppose this is a ulcer, take a piece of foam, wrap it in a piece of gauze and stick with the micropore, and you see it's offloaded. So it can be practiced at the primary care. Even we ask the family members to do this. This is a window walking cast with the total contact cast with window walking. This is a posterior slab, and this is a cast. This is a front offloading. So different type of offloading modalities can be done. So because as I discussed that I am going to discuss more of the preventive part than the management part. So dear friends, diabetic foot is mandatory in all diabetic patients. So examine a diabetic patient from foot to head, apadhamastak, so you are not going to miss the diabetic foot. Identify the high risk, that is our duty as a diabetologist or as a physician. Team members should impart foot care education to all diabetic patients at every visit. Minor foot pathology and trivial injuries should be managed by physicians and team. complex foot pathology should be referred to the higher centers. Complications of diabetic foot, as I have mentioned, ulcers may be neuropathic, ischemic or neuroischemic, Charcot's and the amputation, major or minor. All are common in major health problems, huge economic burden, family and society, both. And frequent recurrence. Recurrence rate, as I told, in 1 year more than 40%. Then high mortality, more than 5 common cancers. Emphasis on prevention is the key to avoid complications. And the most important word, the final word I want to convey, diabetic foot disease is directly analogous to malignancy. And it follows that the person whose foot disease is in remission should receive the same structured follow-up as a person who is in remission following treatment for cancer. Thank you very much for giving me patience hearing.
Thank you, sir. It was a fantastic talk. I think I open the podium for questions. If any questions are there, please.
I have some questions and some comments as well.
Yeah.
First question is, do you believe that pure ischemic ulcer does exist? Pure ischemic foot ulcer?
Actually, frankly speaking, it is basically what I'll say. In India, around when I started diabetic foot around 25 years back in year 1999, around 15% were the ischemic and neuroischemic combination, and 85% were infected in neuropathy. Now we say 1/3 is ischemic, as there is a paradigm shift. As the more aging population, we are seeing more and more ischemic ulcers, and 2/3 are neuropathic infected. So pure ischemic, yes, it exists, because in few patients, because neuropathy, there is loss of protective sensation. But when there is ischemia or ischemic ulcer, they have got severe pain. They are unable to sleep whole night. They are awake. They are just putting their feet on the bed like this. Give me relief. Even some patients come to us and ask them, please go for amputation. I'll be happy, but I'll get rid of the pain. Yes, it exists, but definitely long duration of diabetes and all. So in reality, if you'll ask, then you will say that yes, pure ischemic hardly 10%, but it is basically neuroischemic or neuropathic ulcers are there.
Yes, because if the vascularity is compromised, definitely it should have compromised the nerve as well, because
yes, agree.
Because of the vasa vasorum.
Yeah.
Impairment in the supply of vasa vasorum. That is theoretically also possible, and in the initial stage of neuropathy, there might not be absence of sensation, pain sensation, only involving the small fibers. There could be hyperalgesia, allodynia, etc., etc. And the second question is, do you believe that the pure infective ulcer also exists?
No, pure infective, how come? Infection occurs if it is due to some injury or something else, then only. Infection, once patient in neuropathy, he was walking barefoot and he have some injury or something, tribal injury suppose, and then infection is set up. So with the neuropathy that is there, but if with some accident, suppose some accident occurs in a diabetic patient, at that time it may occur, but pure, you can say, infection cannot occur. It is a neuropathic infected. That's why if you remember, I've used the term neuropathic infected. And what I've discussed, adequate debridement, and so that is there. So neuropathy, pure infection, it is not going to occur in that situation.
So it is described, I think it is described, possibly described, if it occurs particularly over the dorsal aspects or over the lower part of the legs, that can happen. Anyway, so I have some comments as well.
Yeah.
So regarding the nail infections, chronic fungal infections, onychomycosis. So it is very difficult to diagnose or differentiate between the nail dystrophy, which is a common phenomenon in case of neuropathic foot, nail dystrophy, as well as diabetic patients, and in general as well. The patients can also have psoriasis, particularly involving the nails. So these three entities could be very difficult to differentiate. So we could take help of dermatologists as well.
Point is well taken, but one thing, in psoriasis only nail is not going to be involved. There are other lesions will be there in the, I can say, elbow and
might
foot
not
and
be, always might not be, only the foot infection might be the manifestation.
This is very common in diabetic, we used to see. And about the differentiation between this the onychomycosis of nail or the infection, because if the onychomycosis of nail will be there, then generally what we have seen in our clinical practice, that interdigital mycosis, which I have shown you a photograph, is also common if that is there. If it is not there, then definitely it might be simple.
Usually onychomycosis is associated with cornic paronychia also, acute on cornic paronychia or cornic paronychia. So the next question or the comment is, have you seen any atypical foot ulcer because of some fungal infections? I have seen one patient in my lifetime till now.
That is athlete
We have
foot.
proved also,
The
microscopically we have proved. On the very first day after admission, I told my students that this does not look like an usual bacterial foot ulcer
Now, what was the location of the ulcer?
in the dorsal aspect, as involving the toes as well,
I
involving the
tell you.
toes.
So you see, if it is on the plantar surface, means pressure ulcer, pressure area, and this is a diabetic foot ulcer. Sometimes problem arises when you going to differentiate between the Hansen's or it is a diabetic foot ulcer. So Hansen's generally bilateral, but diabetic foot ulcer may be also bilateral, but generally Hansen.
That was an infective, that was a fungal infection, and
so,
proved
but
that was aspergillosis.
On the dorsum, it may happen,
Yeah.
on the dorsum, but not on plantar surface. That is there. And that once, and second thing, if you remember, I mentioned that 15% reduction per week or 50% in 4 weeks is not there, revise your diagnosis. If you are following standard of care, means 3 basic principles: adequate debridement, infection control, adequate vascularity, and adequate offloading, and still the ulcer is not healing, then you, after 4 weeks, you can wait, and then you revise your diagnosis. In that situation, go for a biopsy, and that will prove it.
Yes,
We do
we
it.
proved that with biopsy,
Yes,
and we
yes.
treated, and the lady
Yes.
cured.
Good point. Yes, we all should know. But I told that I will keep my presentation very basic, so that's why I have mentioned. Yeah.
And the last comment or the questions, I invite your comments. I have came across your paper, which you published in some newspaper, the cornic foot ulcer, non-healing foot ulcer involving the bones, osteomyelitis, the role of rifampicin. Yes.
Recently, we have published this paper just hardly a month back in the International Journal of Lower Extremity Wounds, and is a absolutely very peer-reviewed journal. And what we find that difficult to heal or patients who are in osteomyelitis, especially of the forefoot or midfoot. You can divide the foot in forefoot, midfoot, and hindfoot. So if it is a osteomyelitis there, so what it comes, because the most common infection bacteria, as I mentioned, is the staph. And rifampicin is having very good activity against the staph, the gram-positive bacteria. And it is very important. The problem is antibiotic doesn't penetrate on account of the biofilm. And second is some bacteria which are persister, which persist in the bone. So it helps. Rifampicin not only penetrates the biofilm, it helps in removing or killing the persister cells also. So we used to start in these patients with the 600 milligram of rifampicin once daily for 3 months, and simultaneously we started with the quinolone, either a levofloxacin or ciprofloxacin, out of these two. So whatever we give, and it gave fantastic result. We have got a case of series. We have presented a paper on 67 cases, and we have done a follow-up of the control group also. In that group, we have used the standard of care, but not used the rifampicin, and there is a huge difference in all outcomes. Outcomes means ulcer healings, and secondary was the amputation. So in both have improved. So it was a fantastic drug, and right now too we have got more than 100 patients. But believe me, International Group of Diabetic Foot and IDSA, Infectious Disease Society of America 2023 guidelines, they don't recommend rifampicin yet. But I had discussion with Dr. Jude and others. So probably the newer guidelines will come in 2026. At that time, probably they may approve the use of rifampicin. So that is there. But we are using. So we find. Thank you very much.
Quick comment can I have?
Yeah, please.
Yeah, so, sir, thank you very much for brilliantly sharing your wisdom and vast experience. That was really very impressive. And when you said that start from foot, I was reminded of January 1981 when I started my first house job. I was in the rounds, first week of my, housemanship. And my learned teacher asked me, in fact shouted at me, Avichandani, charan spars kiya ke nahi? So I was literally trembling. I didn't know what he was meaning. And since then, he then thereafter very nicely told me, start with the patient's feet. That is your charan spars karo. वहाँ से आप चूकोगे नहीं. So thank you very much.
So I think message is clear. Give a big round of applause to Dr. Avichandani. Thank you very much. I think my message is clear. My job has been done.
My question, only one question.
Yeah.
Regarding the patients treated with rifamycin and quinolones for the management of staph, whether it was MRSA or MSSA?
Can you repeat, please?
No. Patients treated with rifamycin, that is patient present with osteomyelitis, was culture sensitivity done for that?
I tell you, in these patients, what is there, your point is valid. We haven't taken any cultures because bone culture, to get bone cultures is difficult. Either you go from dorsum because you cannot do from the plantar surface.
Yes,
Otherwise, it will be non-healing and it will sinus formation will be there. If you want to do a bone biopsy, you have to do from the dorsum of the foot, or if you are doing a partial amputation or minor amputation, send the bone for culture sensitivity. But what happened? Most of the time, the patient receive the antibiotics so much, long time, 1 month, 2 months, different antibiotics. So always it comes negative. And I quoted a few studies which was done from the veterans study from US. They have also used and they found the same results which we have found. So it was the bone biopsy and cultures has not been done. It has been started empirically.
Thank you, sir. It was a great talk.
Thank you.
I hand over the session to the organizing team for the next session to be broadcast.
Thank you very much. Dr. Ghanshyam Goyal, nice talk. Our trade is running before time. So we have got no signal to proceed right now to the next station. So a 10 minutes break and then we will start again.
It is the time for Endo Halchal, and we have two interesting topics. One is diabetes and endocrine disruptors, that will be dealt by Dr. Devmallo Shanlal. And second topic is autoimmune diseases and diabetes, that will be dealt by Dr. Kaushik Pandit. And chairpersons for these sessions are Dr. Shomu and Dr. Arjun Boiddo and Dr. Binod Chandani. Please, I request all the chairpersons, please take their seats and start the proceeding.
Now we are going to start the next session. We will have two topics in this session. The first topic would be, the second talk, that would be the first talk now, would be delivered by none other than Dr. Kaushik Pandit. So he is the Chief Consultant Endocrinologist, Bellevue Clinic, Kolkata, and research scientist attached with IPGMR SSKM Hospital. He will deliver the topic endocrine diseases and diabetes. Autoimmune diseases and diabetes. We all know that diabetes, particularly type 1 diabetes, it is associated with many other autoimmune disorders because of some shared genetic factors and shared pathogenesis. So how these disorders are actually connected with the common pathogenetic factors and genetic factors, and how one impact the other, the disease course and also the management, that would be delivered by Dr. Pandit. So over to Dr. Kaushik Pandit.
I think one more diabetes is also there, autoimmune pancreatitis, where there is increased circulating levels of immunoglobulin G4, IgG4, and patient presents initially with endocrine disorder followed by exocrine involvement also. Patient presence with progressive weight loss in a patient, and where there is a definite role for steroid to manage diabetes.
Thank you. Respected chairpersons, sirs, my respected seniors in the audience, and dear friends. It's indeed an honor to have been invited by the organization to have my thoughts on this issue. Autoimmune diseases and diabetes. Understanding shared pathophysiology. Well, autoimmune diseases and diabetes. So, is it chalk and cheese? I mean, two unrelated things taken together merely by chance? Or are we talking about autoimmune diseases and diabetes insipidus? Not sure. I mean, the topic that has been given is autoimmune diseases and diabetes. Does it really happen, autoimmune diseases and diabetes insipidus? Well, it does. Though rare, but it is possible that somebody developing autoimmune antibody against the cells in the posterior pituitary and therefore central diabetes insipidus ensues, and that's possible. But surely we're not focusing on this one. So what are you going to talk about? Autoimmune diseases and diabetes mellitus. Of course, I'm sure. I'm just kidding. I mean, obviously the scientific secretary must have this one in mind, that autoimmune diseases and diabetes mellitus, of course. Yes, true. Now what about, is it type 1 or type 2? Well, though it is known that it is usually associated with type 1, but we can also have a close association, a close correlation of type 2 diabetes and some autoimmune diseases like autoimmune thyroid disorders as well. If time permits, we'll probably come back to with the permission of the chair. I may delegate a minute on this one at the later part of the story. So let's talk about autoimmune diseases and type 1 diabetes mellitus. Type 1 diabetes has been known for quite some time. We know about what is type 1 diabetes. In fact, it was described almost very clearly in Sushruta Samhita, 600 years before Christ came to this earth. And there it was very clearly stated that the pattern of diabetes that is there, it is very much commensurate with what we today know as type 1 diabetes. And since then, people have been thinking, the scientists have been thinking about what causes type 1 diabetes. Unfortunately, even today, we really do not know what actually causes type 1 diabetes. So, a lot of thinking had gone behind it, and just because we have understood that this is an autoimmune disorder, that means the antigen must be present inside our body, and there were a lot of time, money and energy spent on this one to understand what can be the autoantigens. People naturally thought about human leukocyte antigen, or HLA, which is associated with so many diseases of autoimmune origin, had found that there is some bit of correlation between DR3 and DR4, and but that's just a correlation. We couldn't establish that exactly DR3 actually causes type 1 diabetes really. And it was also noted that people who have got this DR3, they also have got not only type 1 diabetes, other autoimmune disorders as well, like celiac disease, hypothyroidism, or people who have got DR4, they have got multiple sclerosis and rheumatoid arthritis, etc., etc., etc. And so it is just mere observation that type 1 diabetes, being an autoimmune disorder, also shares some commonality with various other autoimmune disorders as well. So it is understandable that these are in the genes. So a short course would be, just because you have got so much of development in the genetics, probably you can think of going into individual genes, because it's known, mostly known now, after the Human Genome Project, and people try to find out what can be the probable source or probable place where you can, turn down that this probably is the antigen in type 1 diabetes. And as you can see that there are lot had gone into this one. So probably that's not giving us much of information, in the sense that you have got so many genes that you can think of. So we are back to square one. So the next possible course of action to find out the cause of type 1 diabetes would be a genome-wide association. You know, this is a new technology in the sense that rather than finding the needle in the haystack, you turn the haystack upside down, noting each and every one of it, just because you have got the technology now, and try to find out what can be the possible reason for type 1 diabetes and how can that be related to other autoimmune disorders as well. So our knowledge has increased. Now we know there are reasonably more than 136 risk allele that have been found, but we are still not very sure as to what we do about it, how to go about it. Now there is another way of looking into it. That's what is known as meta-analysis. Meta-analysis of Goa's study. There you actually assign the importance of each individual traits or alleles and find out what can be a possibility there. And that's dictated by the p-value. In our standard meta-analysis or in a study, you know the p-value is, or alpha error is 0.5, that is 5%. But in Goa's meta-analysis, the ones which are important has to be below less than 10 to the power minus 8. So it's a very minuscule amount. So if it is, the p-value is less than that, only then it is important. By that, even by that, you have got so many ones. But the one which came out very strongly, which has got a p-value of 10 to the power minus 85. So you know that it's a very, very minuscule number. So the correlation is much, much more. Your precision of determination in that meta-analysis is much more. And that goes by the name of PTPN22. And that's one of the very important genes that you know today. So what is PTPN22? Well, that's present in chromosome number 1, and it is associated with so many pathways, like it is very important in innate immunity, it is very important in T cell signaling, it is also in B cell signaling, and so many things. So one very, very important pathway where it is responsible for type 1 diabetes, and it is commensurate with our understanding of the pathophysiology of type 1 diabetes as well. People are smart enough to understand that this PTPN22 is also responsible for the risk of various other autoimmune disorders, in addition to type 1 diabetes, like systemic lupus erythematosus, autoimmune thyroid disease, psoriatic arthritis, rheumatoid arthritis, ANCA-associated vasculitis, and so on and so forth. But it's surely not associated with multiple sclerosis, pemphigus vulgaris, Behçet syndrome, etc., etc., which are also numerically associated with type 1 diabetes. So it is evident that the story does not end in PTPN22, surely. Some had even numerically assessed this PTPN22 risk factor and found that while type 1 diabetes is giving so much of the risk, nearly 2 times, it is also giving a significant amount of risk numerically to various other diseases like rheumatoid arthritis, SLE, etc., etc. So it's very evident that be it PTPN22, be it something else, these diseases are very much linked. Very much linked, not only by the numbers, but also by the fact all of them are autoimmune disorders. Now, people have also tried to understand these commonality, autoimmune disorders, and the risk genes which are associated. This is from one important study which showed that here there are the genes, here are the diseases, and you can find, I mean, all these are, all of them have got type 1 diabetes plus something else. So you have got aplastic anemia, etc., rheumatoid arthritis, etc. And you can find that they have got, all the colored ones are the ones which is important. So you can understand that in AITD, that is thyroid disease, it is so many lines are there. So in type 1 diabetes and AITD, that is hypothyroidism, you have got these, so many common genes that are there. And these genes have also been found to have functions, and I mean they are color coded in the ones like the ones you can see that the yellow ones are T cell development and cytokine signaling genes. So it is understandable that there is a defect in the autoimmunity in the T cell signaling, which can lead to both type 1 diabetes and thyroid disease, hypothyroidism, or autoimmune hypothyroidism. Similarly, you have got so many other diseases as well, and with a different sort of genetic functions like interferon and NF-kappa B signaling. You can also have apoptotic genes and etc. etc. So now we know reasonably that the type 1 diabetes is related to so many gene defects, and those defects are sort of shared with very many other autoimmune disorders. Statisticians are not left out of the job, and they have also gone into the numbers and done a sort of Bayesian analysis of various genes, like 90 genes or genetic association on risk, and statistical co-localization of genetic risk variants. I would not go into the detail, only to say that just to show that this type 1 diabetes, rheumatoid arthritis, celiac disease, they are also having, by this Venn diagram, you can understand that they are, many of them are, though the number is small, this one probably have got all 4 diseases, this probably have got this type 1 and rheumatoid arthritis, and so on and so forth. So that also has proved that there is association. Now let's look into this one very simple Wellcome Trust, you know, the one who had gone for the Human Genome Project. There they have looked into only 14,000 cases of 7 common diseases. And there, if I just tell you that here is type 1 diabetes and here is rheumatoid arthritis and other diseases like bipolar disorder, coronary artery disease, Crohn's disease, hypertension, etc., it doesn't take you years of training, or it cannot, you cannot miss to see that there is a clear correlation with type 1 diabetes and rheumatoid arthritis, and maybe some Crohn's disease. These are all in individual chromosome and the number of genes which are responsible. So now you can see, without looking into great detail, a simple look into this picture tells you that there is a genetic correlation between type 1 diabetes and rheumatoid arthritis. Of course, there would be many other, those disease has not been seen. How common is this one? How common is association of type 1 diabetes plus something else? We can call it a type 1 DM plus. We have also done our bit from this part of the world. We have done a very small study and published in IJEM, where we have looked into the autoantibody status, not merely the the autoimmune diseases per se, but autoantibody status. And there also we have found that people with type 1 diabetes, confirmed type 1 diabetes, harbor at least 51% have got anti-TPO antibody, which makes them develop thyroid disease, or they have already developed hypothyroidism. Similarly, they can also have tissue transglutaminase IgA antibody. So those diseases, gastrointestinal disorder, are also strongly related. They can also have a minority of them, or 2% of them have gone anti-21 hydroxylase antibody, which is responsible for Addison's disease. So that's a small study. If we go into big studies, the one like this one, this is from Finland, where you have got the, so to say, almost the highest prevalence of type 1 diabetes in the world. And they obviously are pretty worried. Their data says that every 5th individual, so nearly 20% of people with type 1 diabetes also have got another autoimmune diseases. If we go into the detail, if we go into the detail, we cannot certainly go into such a big table. We just restrict ourselves to these two, the first and the second row. The first row is no autoimmune diseases apart from type 1 diabetes, and this is type 1 diabetes plus some other autoimmune disease, any autoimmune disease. It can be rheumatoid arthritis, it can be hypothyroidism, etc., etc. There, if we just look into the numbers, if you go through the numbers, we will see there is actually not much of difference. So far as the phenotypic and the biochemical differences are concerned, there's not much really to talk about. But one thing which strikes is that people who have got only type 1 diabetes, the female preponderance is 40%. So, say only type 1 diabetes, 40% are female, 60% are male. But those who have got type 1 diabetes plus, their 65% is female and 35% is male. So clearly, probably this number tells us that a young female type 1 diabetes has got a high risk of developing something else as well compared to a male one. This simple numbers tell you. And there is clustering of the other autoimmune disorders from that very particular study that they have got hypothyroidism, celiac disease probably the highest, then hypothyroidism and also hyperthyroidism, and hypothyroidism with atrophic gastritis, etc., and that way it goes. Another one study that also has got a very big number that says that once again we restrict ourselves to no additional and additional autoimmune diseases. This shows that from the numbers we can see that age at analysis is 17 and age at analysis with Addison's disease is 28. So it is evident that people who have got type 1 diabetes to begin with, they develop the Addison disease later on, not the reverse way. They develop Addison and then later on develop type 1 diabetes. This simple number tells us that probably this is the takeaway from this particular slide. And if we look into this one from the same study, it shows if we look into type 1 diabetes with Addison, type 1 diabetes with Hashimoto's thyroiditis and type 1 diabetes with Graves' disease, these numbers also tells us a small simple story in the sense that with Hashimoto's thyroiditis and type 1 diabetes is 88%, so rest a minority is something else. So somebody who have got Hashimoto's thyroiditis and type 1 diabetes, they are less likely to develop other autoimmune disorders. In contrast, we will see that somebody who has got type 1 diabetes and Addison's disease, it is only 60%, 55% to be precise. So they also have got the opportunity of developing other autoimmune disorders as well. So this simple numbers tells us a much bigger story. Do they differ so far as their complications are concerned? Probably yes, though the numbers are less. We can see that neuropathy is probably more with type 1 diabetes with Graves. Microalbuminuria, that means nephropathy probably is more with slightly with autoimmune hypothyroidism. And retinopathy is certainly much higher in Graves' disease. So these are the stories, these are the presentation. Now, how does that change the scenario? As a physician, why should you bother about it? Well, they have got an importance so far as changing the effect on the diabetes, and diabetes can also affect that particular autoimmune disorder treatment as well. Let's take an example, like say in Addison's disease. A person with type 1 diabetes with Addison's will have an increased risk of hypoglycemia. And it is understandable that, that people who have got Addison's disease, we give them steroid, and initially you need to measure increase, decrease dosage, and that point of time it becomes a little difficult, a little challenging to control their insulin level because with the steroid dosage changes. So these are the things that needs to be taken into account. They also have got decreased exercise capacity because of the Addison's disease as well. Now, what about diabetes changing the scenario? Well, type 1 diabetes, they have got an increased risk of infection, and that can lead to an Addisonian crisis, adrenal crisis in situations of associated adrenal disease as well. Similarly, somebody who have got type 1 diabetes and Graves' disease, they have, so far as changing the scenario on type 1 diabetes, the glycemic variability is changing. I'm taking a bit of a time simply because of the fact that the first speaker was not there. Okay. So the glycemic instability is more with Graves' disease and type 1 diabetes. And type 1 diabetes sometimes can lead to a bit of a diagnostic confusion in the sense that the person is sweating heavily with tremor. This can be a manifestation of hypoglycemia. This can be a manifestation of uncontrolled thyrotoxicosis as well. So Graves and type 1 diabetes can and give you a bit of a trouble in that situation. In situations of Hashimoto's thyroiditis, their glycemic instability is increased in presence of thyroid disease than it would have been otherwise. The cholesterol level is also increased because of uncontrolled hypothyroid status. And this type 1 diabetes, they at times can go into a state of hypoglycemia, and if it happens in the early morning, there we probably have to give them oral glucose or some sort of oral carbohydrates, and that can have an impact of their dosage of thyroid medication. So that's how they're related. So this is something important to understand, that type 1 diabetes and other autoimmune disorder can influence both. Type 1 diabetes can influence the other autoimmune disorders, and autoimmune disorders can certainly influence the outcome of type 1 diabetes as well. So I don't think we can spend much time on this one. I'll just say that type 2 diabetes and hypothyroidism, they are also can be seen as a sort of strange bedfellows or mutual companions. They can be seen as companions as well. If you go by the number, I mean, theoretically they apparently are not related. That's true. One is degenerative disease, another is autoimmune disease. But even then, just because they are both are common diseases, but the fact remains that this commonality is more than expected by the statistical number of their association. What I want to mean is that just because they are both are common diseases, type 2 diabetes and autoimmune thyroid disorders, the numbers they should be present statistically, theoretically, is much lower than we see in real terms. Why does it happen? Nobody really knows why that happens. But if you go by the numbers, you will see that with time in type 2 diabetes, the chances of hypothyroidism increases, seen mostly in females, but males are not to be left behind. Males also catch up the situation quite fast at the later stages of their life. And if you look into these numbers, you will see that males predominate with type 2 diabetes and hypothyroidism compared to the females. With age, it increases. Non-obese predates or supersedes over the obese. Even people who are negative antibodies rather than positive antibodies. Positive antibodies obviously have got a higher number, but negative antibodies are not much left behind as well. So type 2 diabetes and hypothyroidism, it's a disease of the elderly, increases with time, more seen in males. So that's the message that I want to. Etiology, not really known. But there are connections between thyroid and the pancreas through various pathways, including direct T3 action on the liver, including direct T3 action on the arcuate nucleus and paraventricular nucleus and ventromedial nucleus in the hypothalamus. What do you do as a physician? Simple. You try to diagnose all the thyroid disease and type 2 diabetes or even type 1 diabetes. They can be overt or subclinical. Given the situation of subclinical hypothyroidism, you go as per the protocols. In situations where there is type 2 diabetes, you see whether this is type 1 TP antibody negative or TP antibody positive. If somebody is positive, you become more cautious and try to find out whether they are approaching hypothyroidism fast. So I'll stop here and would invite questions. Thank you very much.
Thank you, Dr. Kaushik Pandit, for your nice talk, and you covered almost the whole topic, how the autoimmune diseases and type 1 diabetes and also type 2 diabetes mellitus are correlated pathophysiologically, and how the one disease can impact the other one. But I can start with the first question, I think. So how the treatment of one disease can influence the outcome of the other?
I mean, as I have noted that both type 1 diabetes changing the scenario of the adrenal or hypothyroid diseases, and the other autoimmune diseases like adrenal disease can also influence the type 1 diabetes also. Like especially in a case of say adrenal disease, Addison's disease, in presence of type 1 diabetes, adrenal disease leads to glycemic instability. The frequency of hypoglycemia is much more than what is expected. So if somebody is having frequent hypoglycemia in a situation of type 1 diabetes, one must think of the possibility of associated adrenal disease as well. The other thing that we need to also think about that presence of type 1 diabetes makes one develop hypoglycemia much more frequently than it would have been otherwise, and that in that situation or in a situation of say type 1 diabetes leading to increased infections, the situation of the adrenal disorder becomes precarious, and there we will have to think of strategies to give them sufficient amount of steroids to cover the situation. So type 1 diabetes and adrenal disease, the adrenal disease might worsen in presence of type 1 diabetes as well. And similarly, many other diseases. Yes, Shamugha.
Many other autoimmune diseases like rheumatoid arthritis,
yes,
where during management of flares, steroids are needed, so that can
also have
influence the glycemic
and
control
all
of the
them
diabetes.
have got an effect on the gastrointestinal disorder, like gastric emptying time also changes, and in such a situation diabetes also is influenced as well.
And on the other hand, for managing rheumatoid arthritis, if hydroxychloroquine is used, that can improve the glycemic control as well. And one disease can influence the progression of the disease course and complication as well, like presence of rheumatoid arthritis or SLE in presence of type 2 diabetes mellitus or type 1 diabetes mellitus can accelerate the cardiovascular disease progression and then also the outcome.
Yes, sir. A nice presentation, highly informative one. So we normally say there is always an interaction between environmental factors in a genetically predisposed individuals to develop type 1. So there are certain preventive studies, immunomodulator like, and we have monoclonal antibodies. So one such monoclonal antibodies in a patient, for example, identical twins or siblings in the family history of type 1 diabetes, autoantibody positive, either normoglycemia or patient presenting with IGT or IFG. Full-blown diabetes is not there, where tepsulizumab is indicated. So that slows down the progression as well as subsequent development of type 1 diabetes.
Yeah, maybe
will it also influence the development of other autoimmune diseases, what you have enumerated?
Unfortunately, I'm sure that this has not been looked into. People have been focused on type 1 diabetes alone with that specific monoclonal antibody, but whether that antibody also delays the development of other autoimmune disorder is, I have not found any reference anywhere. So
right.
with much usage, I'm sure this would also be another very important thing to look into.
Right. Next
Hello.
is, well, managing patient with a type 1, type 2. We do estimate thyroid profile. We come across some of the patients high levels of antibody. We follow the patients, not all. So, with reference to type 1, if the TSH level is less than 10, antibody positive, we initiate the patient on thyroid replacement. Whereas with reference to type 2 diabetes also, we initiate. Right. Rising titer will have an impact on the development of other autoimmune disorders.
TPO antibody is specifically linked to thyroid disorders, but TPO antibody rising titer probably would not dictate the development of rheumatoid arthritis or celiac disease or other disorders. This is very specific for the thyroid disorders alone. That's a good question. Yes,
yeah,
sir.
Dr. Pandit, thank you very much for overtly simplifying such a complex subject with so much brilliance and fluency.